was if it's epiglottis, if it's a normal epiglottis, it can never be picked up with an ultrasound. Only when there is epiglottitis or when there is a lesion, it can be picked up in the ultrasound.
Not only ultrasound, but also X-ray will show what is called the thumb sign.
I just read it somewhere, so that I'll tell you.
Yeah. So the main points about the preoperative preparation for a post-conceptomy is intravenous access and fluid resuscitation is very important. And operating room setup, you must always have two section setup, endotracheal tubes of various sizes, secondary intubation equipment for medial laryngoscope, nasal cannula for applic oxygenation, and the induction technique, RSI. Now RSI, earlier RSI was no ventilation after you paralyze the child with a relaxant. Whereas the modified or controlled RSI is a gentle mask ventilation of less than 12 centimeters after induction of general anesthesia. So this question is also commonly asked in the examination. What is the difference between classical old RSI and the modified or controlled RSI? So regardless of the acute nil per hour time, patients with bleeding tonsil always have assumed to have a stomach full of swallowed blood, and also they might have been given some feed if the duration after the surgery completed and then exploration is more. Oral feeds could have been started, that could also contribute to the full stomach fusion. And more often it is venous oozing rather than acute arterial bleeding. And primary goal is to assess the extent of loss and try to resuscitate the baby as possible. So circulatory compensation will mask the true extent of blood loss until 40% of blood volume is lost to the child. And contemporary pediatric practice endorses intravenous induction for this. So earlier it used to be an option between inhalation induction in the lateral position and intravenous induction, but now it is better to, because you have the drugs available like ketofol which can stabilize the hemodynamic situation, you can go for intravenous induction. The induction agent, this is the discussion between pro and con between various options. So inhalation induction with oxygen sevoflurane, and in hemodynamic patient or compromised patient, you can go for etomidate, ketofol, or relaxant. Option is between sustainetonium and rocuronium for RSI. Intubation, oral route, especially if adenoidectomy has been done earlier. Check the records for previous intubation and use one size smaller. Maintenance, spontaneous breathing for oxygenation, nitrous oxide and sevoflurane, then using Saxa for intubation. If rocuronium is used, you need to definitely control ventilation. And using minimal opioids, as the effects of previous use, they still be there, and some analgesic could have been given post-operatively. Blood transfusion may be necessary if HB is less than 8 grams and there are signs of shock. Recovery, extubate and fully awake in lateral 30 degree head down position to prevent aspiration. So that is all the main points with foreign body, post-conceptual bleeding. Coming to the aspirated foreign body, sometimes they may give a clinical scenario. So I have just given a similar scenario given in the World Federation of Society of Anesthesia tutorial of the week. There is a entire chapter on aspirated foreign body. So this scenario is taken from that. So this is how the child may present, may have stridor or may not have stridor, mild have wheeze, and AP plain X-ray, no evidence of any foreign body. Organic foreign bodies never show up in the X-ray, so you cannot see them in the X-ray. So a normal chest X-ray does not rule out an aspirated foreign body. That is the moral that you have to know. Coming to the etiology incidents, most commonly occurs in children between 1 and 3 years of age, more common in boys, and because they put the objects in their mouth, particularly while running, and they have no molar teeth, so they are not able to chew anything that they are having. So these are the two reasons that have been attributed for the chances of aspiration. And death will occur immediately if it is a complete upper airway obstruction, like a coin getting caught in the larynx or in the trachea, completely occluding the opening. Then it will be instantaneous death. Most common aspirated objects are food, and other things like oil, button cells, and chalk are also aspirated. And diagnosis is difficult unless it is witnessed by some elderly person or adult during the act of aspiration. But presentation can be variable. It can be early versus late, especially if the foreign body has gone on to the bronchus or the lobar level. It will be, the child will not be brought to the hospital immediately. They will be eating, and then when the cough is persistent and not going away, then only they will bring the baby to the hospital after 1 or 2 days also. So early versus late presentation, and size and shape of the object inhaled also matters very much. And the site or location where exactly it has got lodged, like trachea, main bronchus, or distal airways, is another reason for the early arrival or late arrival inside the hospital. And the early presentation can therefore range from severe acute airway obstruction, uh, though a well-thin child may have another cough also. The presenting late is often a sign of a lower respiratory tract infection or a pneumonia. So 90% of the foreign bodies lodge in the main bronchus. After the trachea divides into right and left, to one of the right or left main bronchus where it may get lodged. So the history, it is a sudden onset of choking followed by coughing and wheezing. On examination, if there is cyanosis, stridor, severe intercostal sternal resuscitation, or even reduced consciousness, it requires an emergency management. But these are the only children who have to be attended immediately. And the history of voice change or barking cough may indicate a laryngeal edema or upper airway foreign body obstruction. A late presentation may well include signs of pneumonia, such as fever, cough, tachycardia, tachypnea, and focal chest pains. Investigations, first investigation is oxygen saturation. So a severe obstruction always results in desaturation. Then you take an AP and lateral chest X-rays to see whether there any radio opaque foreign body is there, and this X-ray should include the neck, entire neck also. And if the material is organic, then it will not be demonstrated in the X-ray. So the radiological finding seen are, it may be totally normal X-ray, or there may be gas trapping due to valve-like effect, or there may be a mediastinal shift, or it may be atelectasis or lobar collapse and consolidation. Coming to the management, these are the few questions you have to ask when you want to manage a patient with a suspected foreign body. Does the child have an effective cough? Is the child conscious and having an effective cough? Encourage to cough the child by itself. Do not try to do any physiotherapy or interventions, because you can dislodge the foreign body and cause a worsening of the obstruction. So as long as the child itself is trying to cough out, it will have more effect and more powerful cough to bring it out. So in a conscious, well coughing child, allow them to cough enough to bring the foreign body out. Do not do any maneuvers or intervention. But if the cough is very weak, sluggish, and not very effective, find out the conscious state. If the child is conscious, then you can do what is called the back blows and chest thrust and all those things. Only when the cough is ineffective and the child is conscious. But if the child is not conscious, then the airway breathing circulation approach should be done. ABC approach and basic life support guidelines should be done. So this is how you classify the management of a child with an obstructed foreign body airway. And most children who reach hospital with an inhaled foreign body will have partial obstruction and an effective cough. So once the child has been assessed, arrangements need to be made to transfer to theatre with appropriately skilled senior personnel of bronchoscopy. It is not the learning time for a junior one. So person who is more experienced, because it's a life-threatening situation. So there is no place for learning curve here. So all that has to be done in mannequin and learn. So yes, experienced personnel should be available to do a bronchoscopy and general anesthesia. As she mentioned, gold standard is by ENT surgeon or a pediatric surgeon using a rigid open tube bronchoscopy. But successful use of flexible bronchoscope has also been done in some situations using urethral stone baskets and forceps. And so this is how the rigid bronchoscope looks like. For the sake of those who have not had an opportunity to use all these instruments and see and handle a case like this. So this is how you can see the rigid bronchoscope always has an attachment available for ventilation. So that is the biggest advantage. As an anesthesiologist, you can be more comfortable and the surgeon uses the rigid bronchoscope. And this is the retrieval forceps. This can be introduced through the same eyepiece. And this is the position how it looks like. These are all the various sizes of all these bronchoscopes that are available for use at different age groups. And this is the flexible bronchoscope. If you see this, this has got the light source connection, the wire, and then there is no attachment available for ventilating the patient. So for this, you have to use a LMA like this, and then connect it to the scope, and through that only the surgeon has to pass through. So with this being a smaller size, it will go through easily through the trachea, and there will be a lot of gap. So LMA can ventilate through the sides of this flexible bronchoscope. So that is how you maintain the ventilation if the surgeon prefers to use the flexible bronchoscope. And this is another method of continuing the ventilation using, even if you don't have the regular thing, you can use an ambu bag also for ventilating. And these are all the retrieval equipments which you can use with the flexible bronchoscope. Unlike the rigid bronchoscope where you have that thing, these are all the urethral baskets and other gadgets which are used for retrieval of the foreign body. So common practice is to use a rigid bronchoscope in most of the institutions. Why? Because availability of foreign body removing equipments that fits down the lumen of bronchoscope is more available with the rigid bronchoscope, and many operators are familiar with that, and we are able to deliver oxygen or even anesthetic gases to the side off. So these are the three main reasons for using the rigid bronchoscope. And the key to success is communication between all medical staff with regard to planning and execution. And technique of anesthesia, one is preparation. We can't expect an ideal fasting time depending upon the emergent nature of the foreign body, where it is lodged and how severe the obstruction is. You have to sometimes accept the baby even with a full stomach. If it has eaten something and then aspirated the foreign body, you cannot expect, you can't ask the baby to wait. So you have to accept the full stomach situation and be prepared for that. Anticholinergic premedication will help in reducing the vagal induced bradycardia in pediatric patients, and also block the reflex bronchoconstriction that may happen because of the manipulation of the airway, and reduce airway secretions. Already the child is drooling because of the obstruction, that also can be reduced. Antibiotic and steroids also can be given as a preventive measure before you take up the patient. So anticholinergic, antibiotic and steroids are all given as a preparation. Coming to the induction, inhalation induction was the mainstay for many long years in most of the textbooks, with sevoflurane or halothane to in oxygen to use spontaneous ventilation and preserve the spontaneous ventilation. Sorry. Nitrous oxide is usually avoided for induction and maintenance. Particularly, there is a radiological evidence of gas trapping. And once adequate depth is achieved by using the eye signs, respiratory pattern, abdominal wall tone, especially the eye should not be moving. It should be fixed and in the central position. That is the ideal state for assessing the inhalation induction, the depth of anesthesia. And once that is come to that stage, you put in a scope and you can spray the vocal cords and upper trachea with 4% lignocaine. And then this will help to reduce the cardiovascular and passive reflexes. That is, coughing will be less, and the cardiovascular hypertension and stimulation will be less. An alternative is to go for IV induction with fentanyl 0.5 microgram followed by increment boluses of propofol until the child loses consciousness. And the current technique is to go for IV dexmedetomidine 1 microgram per kg. And the maintenance spontaneous breathing technique is superior as it reduces the chance of distal movement or dislodgement of the foreign body. So Nagaswamy is connected to the side arm and allowing maintenance of anesthesia by oxygenation and ventilation. And second reason cited for spontaneous ventilation is when a bronchoscope is passed more distally, oxygen and volatile can still go through to the lung through the sides of the bronchoscope. So the oxygen enters gas entrained from the bronchoscope through improving the oxygenation. The alternate method for that is to paralyze and use positive pressure ventilation. This technique is superior because the coughing and desaturation episodes are comparatively much less compared to spontaneous respiration. And also it reduces the incidence of atelectasis and overcomes the resistance to breathing through bronchoscope. So these are the pros and cons of both spontaneous and controlled ventilation. And intravenous maintenance, if you go for total intravenous maintenance, the need to use the airway to administer anesthesia is not required at all, and especially when the airway is reduced. So there is less exposure of the operating theatre team to waste anesthetic gases. That is the reason why nowadays they prefer to go for TIVA also for this. And during initial maintenance phase, deepen the plane of anesthesia until the patient is deep enough to tolerate the application of topical local anesthetic. And then after application, again continue ventilation, wait for a few minutes for the local anesthetic to take effect. Then you can put a supraglottic LMA also, device also to maintain the patent airway. And then you can give titrated doses of opioids to reduce the ventilatory frequency. Commonly, these children will be breathing at a very fast rate. So you keep on giving fentanyl to the extent that the respiratory rate comes down to almost 50% of what is the rate when the child was conscious. So that is the way in which you titrate the opioid. The rule of thumb is to aim for half the preoperative respiratory rate. Then titrate propofol to the respiratory pattern, muscle tone, and heart rate. And children under 3 years of age tolerate higher doses of propofol and remifentanil. So don't think because the child is small you have to give less. They may need more. And dexamethasone 0.25 to 0.5 is given to prevent airway swelling. And perioperative complications of foreign body removal are in the airway, you can have laryngeal edema and complete airway obstruction when you are trying to inadequately anesthetized child. If the child has a bout of cough, the foreign body may come and get lodged, and where from it the removal is very difficult. And sometimes we may fail to remove the object. And in the breathing, you may have hypoxia, hypercarbia, coughing, pneumothorax, regurgitation, and aspiration of gastric contents. In the circulation, it can produce dysrhythmias and cardiac arrest. Neurological, it may cause seizures secondary to hypoxia or hypercarbia. And other, sometimes even death on the table is quite common. Post-operative care, clinically well, if the child is coughing, not coughing, conscious, saturation maintained, the discharge can be done the same day. There is no need to keep them under observation or anything. And if at all there is a delayed treatment, it comes as a pneumonia, so that can be treated with antibiotic in a conservative manner. Coming to acute epiglottitis and croup, It's a life-threatening disorder with serious implications in the anesthesiology because of the potential for laryngospasm and irrevocable loss of airway. So complete obstruction will again be life-threatening. And it's an inflammatory edema of the arytenoid area epiglottic folds and epiglottis. So this picture here shows a normal epiglottis, normal arytenoid area epiglottic fold, everything. When it is an acute epiglottitis, this is how it looks. They have just put in a small bougie to show where the glottic opening is. Compared to this, you are not able to see anything. So that is how the whole epiglottitis will occlude the airway, and it is mostly above the larynx. So it can be ideally called as supraglottitis also than epiglottitis. So I think it can occur at any age. It is not an emergency in the children alone. It can occur in adults also. And the causative organism, I think she mentioned. Earlier it was Haemophilus influenza, but after the vaccination, beta hemolytic streptococci, which are causing as a sore throat for rheumatic fever. That is the same organism can cause this also. And diagnosis and symptoms, typical presentation is acute occurrence with high fever, severe sore throat, difficulty in swallowing, with a sitting up and leaning forward position to enhance airflow. So this is how the child will be looking with the open mouth and drooling saliva, and usually drooling and difficulty and pain on swallowing both will be there, and it causes also generalized toxemia. And the most common differential diagnosis is croup or a foreign body in the airway. So that is why all these three are given as the same in majority of the textbooks. And what are the 4 Ds of epiglottitis? Drooling, dysphagia, dysphonia, distress respiratory effects. And the patient adopts what is called the tripod position, sitting like this with the hand resting forward and the head lifting up. And do not examine the throat or do throat culture in these patients. What you have to do is reassure, keep calm, anticipate intubation. This is what you have to do. So this is a comparison between epiglottitis and croup. No seasonal predilection. This is more common in winter. Croup is more common in winter. This is more acute. This is more gradual. In epiglottitis, there is no cough at all, whereas in croup, there is always a barking cough. And drooling and dysphagia is very common, whereas no drooling in dysphagia. So these two important facts: no drooling, no dysphagia, barking cough, think of croup. Cough, no cough, drooling, dysphagia, think of epiglottitis. And what are all the radiological and lab findings? There is a blurring of tracheal air shadow, symmetric narrowing from subglottic to the lower area, what is called the church teeth in the AP film of the neck. So you have to take an anteroposterior film. And stridor, tachycardia, tachypnea, and the so-called thumb sign is present in most cases in the lateral express of the imminent airway compromise in lateral clinical dissociation. Because of the risk of inducing laryngeal spasm or total airway obstruction, even examination of the pharynx and larynx should be attempted only in the area with adequate treatment and staff prepared to intervene when the obstruction develops, especially like the area in the operating room. Ultrasonography can be used to detect the epiglottitis, which will produce what is called the alphabet T sign in the longitudinal view of the thyroid hyoid membrane. So this is how the whole thing looks. So epiglottitis produces what is called, you can see T-like shadow. So these are all the swollen things. This is the hyoid bone. So it looks like an alphabet T sign, and this is how you put your probe to visualize that. So you extend the neck and put the probe under the chin like this to extend that. And epiglottitis should be treated as medical in the airway emergency. In the presence of respiratory distress, diagnostic procedures, radiography are not indicated. Securing the airway is the priority. So tracheal intubation of a patient with epiglottitis must be regarded as potentially difficult procedure, and with all monitoring, you should do it only in the operating area with maintaining the spontaneous ventilation. And a team capable of performing an emergency tracheotomy should be readily available. Anytime anything goes wrong, you fail to secure the airway, you must be immediately doing a tracheostomy. And patient to be transferred to the operating room under the supervision of an experienced anesthesiologist and surgeon. And induction may be preferred with patient sitting up. Forcing the child or the patient to supine position itself will cause an acute obstruction. And deep level of anesthesia with maintenance of spontaneous ventilation is the safest method, but the time needed may be prolonged because of the narrow opening and ventilation may be low. So you have to patiently wait and necessitate gradually increasing the concentration. Capnography with exhale gas analysis will help you also to determine the depth of anesthesia. Muscle relaxants are to be totally avoided. Electrical tube with a smaller diameter than predicted is preferred. When unable to see the glottic opening, asking the assistant to press the lower sternum may make air bubbles come out of the trachea through the glottic opening, and that will give you a clue to pass a bougie and then thread your tube. And you must perform, once the child is settling down after recovery, a cuff leak test, which we normally perform after a thyroid surgery to find out any evidence of tracheomalacia. That test is performed here before extubation to know whether the edema is fully subsided or not. So if there is a leak positive, that means the edema is subsided and there is a gap between the tube and the trachea, so you can easily extubate. So these are the points that we